Okay, guys, I hope you're hanging in there. We're moving down even further into the airways, and we're now going to be talking about the anatomy of the bronchus. I know this is riveting stuff, and you guys are probably on the edge of your seats. It's just kind of what you got to get through. This unit, especially, I feel it's just the foundation for learning the concepts coming up. And I know it's a little bit dry. We just got to kind of power through. And hopefully you'll start to find more concepts and interesting applications as we move through this class. If I can get to the next slide. Okay, so this is an Egan diagram of the bronchus. You guys don't have to know all the different cells or the fact that, there's all of these different layers. I'm going to kind of show you the parts that I'm interested in. Like right here, this shows you a goblet cell, which is how we produce mucus. And I'm going to kind of breeze by this diagram. I include it because in Egan, it labels all the different things and it shows the cross sections of a bronchus, but it's not my favorite. So this shows you the layers of the bronchus in a different way. The only things that I personally care about, I will tell you. If I don't mention it, then I don't care about it, in the sense that you don't have to memorize it, and I would never test you on it. So here comes the things that I care about. I care about the gel layer and the sole layer. This is why. You have all of these little hair-like structures called cilia, and we're going to talk about those in more detail as we move through this lecture. But the cilia hang out in what's called the sole layer. And what that is this nice, liquidy, serous level that allows that cilia to wave back and forth and move mucus and secretions and debris out of the lungs. And it does this via what they call the mucociliary escalator. So what that is this constant waving of the cilia in the direction out of your lungs that is always moving out debris and pathogens that shouldn't be there with your secretions. The gel layer is what traps those things. So the gel layer is more sticky and thick, and generally what can cause problems if you're dehydrated or you have a pneumonia or something that's causing this to be a thicker layer than what it should be. And those two layers work together to really kind of keep those lungs cleaned out. There are many different disease processes that involve mucus production or retention that we as respiratory therapists have to come up with treatments for. If you have too much mucus in your lungs that's not getting cleared out, you can collapse areas of your lungs. You can cause real blockages. It can be really life-threatening, to be honest. There have been people that have mucus plugged because they had such dried secretions that were not properly being brought out of their lungs that it collapsed an entire lung and caused extreme work of breathing. And if they didn't have an intervention fairly quickly, it would have been fatal. So seems simple, moving gunk out of your lung, but it's a very important process that can have a lot of things go wrong with it. The other thing I want you guys to know is the goblet cell. I want you guys to know that the goblet cell is what produces the mucus. So that is really important for you guys to know. I'm not going to test you on anything else with this diagram. Those are the main points that I really want to emphasize. Again, because I like duplicate diagrams, enjoy that. You have your cilia, again, which are those hair-like structures that move things out. This is showing you the mucus. This is just showing you those goblet cells, again, producing that mucus. You don't have to know about the columnar epithelium, although that is what it is made out of. I'm not going to test you on that. So discussing the cilia in more detail. Again, me and my diagrams. This is your gel layer, which is going to be thicker than the sole layer. The sole layer, you want it to be very, very thin and serous because that's what's going to allow that cilia to move. All of your debris and junk that is trying to come out of your lungs is going to get trapped in that gel layer. It's all created by these goblet cells, which you can see where they are located. And again, those are the only things that I'm going to make you know in a diagram for an exam. The rest you can disregard. This shows it from another vantage point, really showing that movement. I maybe didn't need so many diagrams, regretting it as I'm doing this recording, but hey, you will have a lot of viewpoints of this fairly simple thing that apparently I thought needed 18 diagrams. So sole layer, moving the cilia, gel layer, moving it up and out. I hope by now you guys will have that kind of memorized. This is going to show you just that mucociliary escalator. And I just want you guys to see how it's moving things up and out of the airway. And it's incredibly important that this functions well. One of the things that you guys are going to hear about, I think in disease they start talking about it, but when you guys go in your clinical rotation, if you're a smoker, there are chemicals in cigarette smoke that actually paralyze the cilia. They stop them from moving. So one of the things that you'll notice about people who smoke or hear from their own kind of description of what's been going on when they come in the hospital is in the morning, they'll talk about how they cough up a lot of phlegm. Always in the morning, they cough up a lot of phlegm, they cough up a lot of mucus. And the reason that that happens is, generally speaking, people don't smoke through the night. So they have a period of 6 to 8 to 10 hours that they're not having a cigarette, and that cilia actually starts to move again and become functional again. So it can start to move out the debris that it wasn't moving out through the day. So generally speaking, they have a very productive and phlegmy cough in the morning because those cilia are starting to function again. They have their first cigarette, they're paralyzed again, and that secretion retention happens again. So for people with COPD and specifically like bronchiectasis, which is one where they have a hard time clearing secretions, sometimes they can suffer from more mucus plugging or pneumonias because those cilia are not functioning the way that they are meant to be functioning. This is kind of a closer movement of the cilia and how it does like a whip-like action and how it moves those secretions out. This is a cool animation where it really shows the goblet cell and how it produces the mucus and moves the debris out. You guys can watch that on your own. And then why do we care about all this bronchus anatomy? And this is kind of where I want to really remind you guys that all of this dry anatomy and physiology that maybe is not the most fun to get through and throw on flashcards and repeat over and over again is all going to link to treatments and therapies and diagnoses that you guys are going to be part of when you're in clinical practice. All of this leads to the job that you guys want to have. So try to keep that in mind when it's midnight and you're on your 50th flashcard and you hate your life. This is all going to matter when you start to get to the clinical application. And the better you know this stuff, the easier that is going to be as you move through this program. And it's going to make you better clinicians. So when you're looking at the anatomy of a bronchus, right, this being a normal bronchus or airway, you can kind of think about it in the lung. And this is one that's narrowed. Okay, so if you want to think about air traveling through these to different parts of the lungs, and all of a sudden you're having obstructions or narrowing, that is a big problem. That's going to limit airflow, and that's going to do a lot of bad things for that patient. There's a lot of different things that can create that narrowing. This shows a couple of them. So this shows a normal bronchus, and then this shows swelling. Swelling can happen because of asthma or COPD or other allergen type processes where that tissue gets inflamed. This also shows mucus building up in that airway, and you can see how much of that airway mucus can take up and how problematic that can be for a patient. This is also showing, again, that mucus production blocking up the airway. And in this one, it's showing it really taking up almost all of it. So this would be what I would consider a mucus plug. It's almost completely blocking off that bronchus and probably stopping airflow to either that segment or that lobe or that lung completely, depending on where it's located. And then this shows a muscle spasm. So although you don't have to label it, an important thing to realize about your bronchus or bronchioles, airways in general, is that they are made up of smooth muscle, okay? And smooth muscle can contract and relax. And when you have a muscle spasm in your airway, and that can happen, it's called a bronchospasm, coming from the fact that you can have a muscle spasm and it's called a bronchus, so a bronchospasm. That is a phrase you guys are going to hear a lot. Bronchospasms are very common with patients who have asthma. And what that is like a hyperreactivity of the airway to potentially an allergen or cold air or exercise where it creates a smooth muscle spasm and that airway will contract down or bronchospasm and that really limits airflow. That's why you will hear wheezing or see work of breathing increase. COPDers also chronic obstructive pulmonary disease. I don't know if I ever said that acronym out loud, and sometimes I do that where I use an acronym that you guys may not know. They also have a lot of bronchospasm issues where those airways are spasming and contracting down. They also have usually baseline inflammation and they also usually have increased mucus. So they can be kind of a trifecta of issues with their airways. So this is why we care about it. This is kind of the foundation that's going to lead you into more detail so that you guys are going to understand all the ways that we can treat these different issues. This is a video that explains the mucociliary function that is compromised with cystic fibrosis patients. I find this really interesting because it just, again, really solidifies how important your cilia are, how important normal mucus production is for the health of your lungs, and what can happen when that is compromised. You guys will not be responsible for knowing like the sodium channels and all the biochemistry behind this. But I just think cystic fibrosis patients are a large part of our patient population that we treat. And this is a chronic issue that they have. So I just included this because it, again, just really drives home the point of the importance of this. And then again, you have your lecture questions. You can refer to the due dates in the calendar, and I'll probably post them under an assignments tab as well.